Hey guys, so this presentation is on autism spectrum disorders. This is going to be your introduction to this content, but we'll be finishing this up on next Tuesday. I want to make sure that or I want to encourage you to read the readings that are posted on Moodle, as well as anything that is written on the syllabus. I have posted a link to Autism Speaks, as well as for a link for the diagnostic criteria for autism from the DSM-5. And then there's also an AOTA autism fact sheet that I'd like you to look at. There's going to be 2 questions posted in this presentation, and you're going to need to have some availability to look at the diagnostic criteria on the DSM-5 in order to answer that. So let's get started. So here, this is an estimation of autism prevalence in 2018. So if you notice back in 2004, that's where they really started to identify and hone into what autism is, and the diagnostic criteria started to become better formulated. And as you see here, it was 1 in every 166 children were diagnosed with autism. Now the rate is up to 1 in 59 children are diagnosed with autism. The rate is higher for boys than it is for girls. There's studies that are out there. There's a lot of research going on. There's some studies that show, even among identical twins, that if one child has ASD, then the other child will be affected between 36 and 95% of the time. But if a parent has non-identical twins, and if one child has autism, then the other is affected only maybe like 1/3 of the time, so 0 to 31% of the time. So there seems to be quite a genetic link to this, but research yet has not, or medicine, has not yet found that genetic link. Parents who have one child with ASD have a 2 to 18% chance of having another child with autism spectrum disorders. So as we talk about later in this presentation, I'm going to be sharing about how and where children can get diagnosed. So ASD tends to occur more often in people with certain genetic or chromosomal conditions. Actually, about 10% of children with ASD also have been identified as having Down syndrome or Fragile X or even tubular sclerosis or another chronic disorder. About 44% of children identified with ASD have an average to an above average IQ, and children who are born to older parents are also at higher risk of having ASD. Small birth weight or children born prematurely have a greater risk of having ASD. Actually, a small percentage of that, I should say, but they are at a greater risk of having ASD than children that are born full term. And ASD also co-occurs with other developmental, psychiatric, neurological, and chromosomal or genetic disorders. Co-occurrence of one or more developmental disorders with a child with autism is 83%, so it's pretty high. A co-occurrence of one or more psychiatric disorders is about 10%, so much lower, but still prevalent. Okay. So when we're looking at the ASD diagnostic criteria, there's 4 things that we look at. We're going to talk much more in detail about this as we go into next week, but I just want to highlight some of the main things. So the first criterion is that the child needs to persist with deficits in social communication and social interaction across contexts, so across various settings. It's not accounted for by general developmental delays, and it must be manifested by 3 out of the 3 symptoms. So as you see here, it has delays in social emotional reciprocity, deficits in nonverbal communicative behaviors, and deficits in developing and maintaining and understanding relationships. So what I'd like you to do is I want you to give me an example of what give me an example of what you might see or characteristics you might see in a child that has deficits under 1, under 2, and under 3. The next area is B. So this is restrictive repetitive patterns of behavioral interest or activities is manifested by at least 2 out of 4 symptoms. C, symptoms persist in early development, early childhood at approximately 8 years of age or younger. And then under D, symptoms can cause clinically significant impairment in social, occupational, and other important areas of function. So what I'm going to do here is stop again, and I'd like you to give me 2 examples of some of the symptoms or characteristics that would be identified under the letter B, as in boy. B as in boy. Okay. Going to the next area is functional limitations. So we're going to work with these terms much more when we meet in class. But when we talk about diagnosing a child with autism, many families or parents will ask, how severe is it? Are they on the mild end? Are they on the severe end? Do they have Asperger's? There's a lot of things that go around. We don't really categorize autism in that way anymore. So what we do is we categorize in the level of need in terms of the functional limitations that a child has. So we look at 2 different areas, and we identify that a child has ASD at like a level 1, ASD at a level 2, and ASD at a level 3. When we talk about level 1, it means that the child requires support. They require support in social interaction skills as well as in communication. We also look at level 2, which is requiring substantial support. And then we look at level 3, which is requiring very substantial support. So we're going to talk more about this next week, but I would like you now to give me, in your own words, write down or share with me a difference between these 3 levels, not just telling me that one requires more support, but what would a child look like, or what characteristics might they present with that might be different between a level 1, a level 2, and a level 3. So I want you to just give me a difference between these 3 levels. Okay, in order to make a diagnosis, there's pediatricians, certainly it's within their scope of practice to make the diagnosis. However, we find that often the pediatricians will send a child or send the child and their family to a neurodevelopmental team. And the reason why they do that is pediatricians maintain a relationship with families, and they want to make sure that they stay on their good side, essentially. So they may make recommendations, they may say that they feel a certain way, but they tend to not make the diagnosis. They usually send them to a developmental evaluation team or a neurodevelopmental team. And then what happens there is when the child comes to one of these settings, and we're going to talk about what that looks like in a little bit, we review a lot of information. So we're not just making a diagnosis for a child based on just seeing them one time. We review school and therapy records. We look at any early intervention reports that were done or any early intervention records. We interview parents. Parents will also create or complete checklists. The people that are part of the neurodevelopmental team are experts in the field of completing discipline-specific assessments and then working together collaboratively within a multi-team focus to come up with a diagnosis. So psychological testing will look at gaps in scores. A speech pathologist is going to look at language delays and reciprocities. They're going to look at the fluidity of the language. They'll look at the functional language, such as, is the child echolalic? Are they scripting? Do they have rote statements? What is their eye contact? What is their joint attention? They're looking at a variety of things. The other thing I wanted to talk about with a psychologist is they will often administer an IQ test, but the overall end result of an IQ isn't as important to us or important to the family as those gaps in score. So we want to see if a child has strengths in one area versus another. Another person or another discipline that is part of the team is an OT. An OT looks at a child's motor skills, sensory skills, motor planning and practice. They look at their level of independence with ADLs and self-help skills, or ADLs. They look at social emotional. And also a PT might be involved to look more at the gross motor aspect and praxis as well. Then we look, sometimes there's a social worker on the team, sometimes there's even a psychiatrist on the team. And we also often have a pediatrician on the team as well to look at the medical piece. So even though we're each evaluating this and assessing our own area of discipline, we pull everything together and we have usually a very deep and great conversation. The last person that can actually make these diagnoses is a pediatric neurologist. Again, by the time the child gets to a neurologist, they most likely have been through a neurodevelopmental evaluation previously, as well as their pediatrician has made that referral. So when we do the diagnosis, we kind of talked a little bit about different interviews and questionnaires that go into play, but and again, we're looking at the medical history, what is the social development, what are the child's developmental milestones, and did they miss any of these milestones? Or more alarmingly, did they make a milestone or meet a milestone and then lose those skills? We also look at other medical conditions because remember, we can't diagnose autism if there's other factors medically that are going on with this child. We look at the family history because we know that there's a genetic link. And then we also look at the family functioning and circumstances. We would not want to we would not want to have a child diagnosed with autism if in fact maybe they were in an environment that was not stimulating to them or that was causing them harm or causing them to not be able to have those social norms or those social roles that would be expected. So there are two assessments that can be used to determine a child's level and the probability that they could have autism spectrum disorder. The first one is called an ADOS, which we're going to talk about this in class more, but it's the Autism Diagnostic Observation Scale. And the second one is called the CARS, and this is a Childhood Autism Rating Scale. We'll be talking about them more in class next week. Okay, so in class, when we meet again, we're going to be discussing the DSM-5. We're going to talk about the specifics for the diagnostic criteria, and then we're going to talk about different therapies that might be involved with the child. Okay. The other thing that I want to bring about is on Tuesday, you're going to need to have your PEDS inquiry for autism spectrum disorders with you when you come to class. This is a poem that you're going to write about autism or about sensory integration, and this is going to just this is your perspective. So after you do your readings, think about it, and then create this poem based on maybe a family or a friend or an idea that you have about autism. It can be anything at all that you want that really is specific to what your thoughts are. I will be collecting all of these, and I've been keeping them with the hopes of kind of creating some kind of book with all these poems in it. So please make it great, at least to the best of your ability. I'm excited to read them. Okay, guys, that's it for today. I hope that you enjoy your day tomorrow, and I will see you in class on next Tuesday. Call me or text me if you have any questions. Thanks.